In today's webinar, we'll look at a summary of key points relating to plantar fasciitis, highlight some points that relate to orthotic prescription, introduce the 4-step DOLA process, a clinical pathway for orthotic prescription. We'll look at how to prescribe and manufacture orthotics for the different feet that present to your clinic with plantar fasciitis. And we will also look at some patient-ready options for those of you in clinical settings that don't have access to grinders or glue, but still need a ready-to-dispense option selected for your patients. Plantar fasciitis has been called by many different names over its terminology journey. This is due in part to the fact that patients will present with multiple tissues involved in their pain, including the fascia, the bursa, the intrinsics, the fat pad, and they may or may not have a bone spur. There has also been a lack of consistent inflammatory markers, changing it from plantar fasciitis. In terms of the causes, it is now just not thought to be a traction injury, but also involves shear, elongation, and compression forces. So it is currently called plantar heel pain. It's reported that 10% of adults will experience an episode of plantar fasciitis or plantar heel pain during their lifetime, and it accounts for up to 25% of foot injuries in sports and exercise populations. Plantar fasciitis, heel pain, and arch pain are very commonly Googled terms, and there are many products sold online and in pharmacies and sports stores and supermarkets with a focus on plantar fasciitis and foot pain. So patients will present to your clinic generally due to the pain or discomfort plantar heel pain causes, which can very quickly interrupt daily living or sports and exercise. In your history taking, it's common for patients to report a gradual onset or it getting worse over time. There may have been an initial event that you can isolate, maybe a footwear change or activity change, but often this can't be isolated. Characteristically, it will have that morning pain or pain after rest and improve with movement, but it depends on the other tissues that are involved. During sport and exercise, patients report that it can gradually get better for a period of time, but then again, after, depending on the tissues involved, can be aggravated. It depends on the combination of tissues involved. Is it just the fascia at the origin, the fascia within the band? Does it involve the bursa? Does it involve the fat pad? Or does it involve the nerve? We follow a clinical pathway or steps that are involved in the diagnosis of plantar heel pain. So most often this will be based on history, physical examination, some assessments, and then imaging if required. But patients can often point to the exact point of pain, which will again narrow down your diagnosis. There can be localized tenderness or pain and palpation of the area of the fascial origin or at the medial tubercle or along the band itself. There might be pain when you squeeze the fat pad. There could be increased pain when you dorsiflex the first MPJ, just like with the windlass mechanism. There could be nodules along the fascia showing chronic injury or scarring. Increased pain with ankle dorsiflexion, so again, the link within that sagittal chain. Localized pain or swelling at the medial calcaneus around where the bursa is, that could indicate that. But generally, there'll be a lack of overall swelling, which will indicate more the chronic plantar heel pain rather than a more severe kind of injury like calcaneal fracture or a fascial rupture or a muscle injury in the area. Many different patient types will hobble in with plantar heel pain. Research, however, does suggest some trends. It will be both in your sedentary and your athletic populations. People with good footwear habits and also poor footwear habits, generally there'll be the trend to a higher BMI. Again, females more than males, but that might just be that they present more often. In the athletic population, it's going to be your ballistic jumping sports or change of direction sports, so basketball, tennis, all of your football codes due to the poor footwear involved in football boots compared to other athletic footwear types. And in terms of occupations, it's going to be the people who weight bear or stand a lot, like your factory workers, trade workers, retail workers. I want to highlight this slide because it then relates to what we're going to talk about later in terms of the orthotic prescription and orthotic design. Plantar heel pain will present in various foot types and various biomechanical styles. So it's not just one foot type all the time that comes in with this. It's across all the different feet that we see. You will see quite a neutral foot, that when you do all of your assessments and your measurements, it's all within normal limits. Nothing is standing out, but there'll still be a reason that the fascia is being overloaded, or still a need for you to help the fascia in its role and reduce the strain on it to allow it to actually heal. So that could be activity demands, work demands, poor footwear, etc. In the pronated foot, it can present for a variety of reasons. One can be the loading, but another big one in the pronated foot, which we'll discuss a little bit later, will be that impact on the windlass mechanism or impact on propulsion, where it is resulting in an increase in force through the fascia because we have that impaired dorsiflexion of the first MPJ through propulsion. In the cavus foot, there's a lot of different types of cavus foot. The cavus foot, which is poor in terms of loading, which again can impact the fascia, but also in terms of impaired propulsion, so through lesser toes in terms of a low gear toe off versus a high gear through the first MPJ. In a lot of these feet, in terms of foot types, you just need to look for that sagittal plane function. So are we dealing with ankle equinus, and are we dealing with functional hallux limitus or impaired propulsion? That could be a real kind of like sign that this person is either prone to plantar heel pain, or that's the cause of plantar heel pain. So this really highlights the need or the opportunity for us to do the correct orthotic prescription for these patient types. These individual presentations are not just giving the same orthotic all the time. So if we understand the tissue stress and the overload will be different in these presentations, we can then understand that we need a different orthotic. So just moving on from that last slide, the plantar fascia has a role in all different foot types and all different mechanics. So it has an important role in just stabilizing the foot or stabilizing the arch. The osseous structures of the foot won't actually hold themselves in place without the help of soft tissues. So the plantar fascia, along with the tibialis posterior, the flexor FHL, FDL, are all needed along with the intrinsics to help just stabilize the foot in all of its roles during gait. So that can be a way that it's overloaded. As we spoke about, in terms of propulsion and resupination, it has a vital role to help stabilize the first ray and plantarflex. So if there's any reason that it's in a dorsiflex position, this is going to increase the amount of force through the first MPJ and through the plantar fascia during trying to initiate windlass and therefore propulsion and toe off. So that's where the highest forces are generated during with the plantar fascia. Again, like what I just talked about on the previous slide, there's a concept of the reverse windlass. So let's just think about that in terms of loading of the foot. During loading of the foot, pronation is what we want. It helps dissipate force. This will result in a lowering of the arch or a elongation of the plantar fascia. So again, especially in the pronated foot, this could be where there is actually some traction and elongation beyond what the capacity of the tissue is, and also where the most shock is in terms of the fat pad absorption. So this could be where there are the etiological factors behind your plantar heel pain. So understanding that it's not just a traction injury, and that could be shear involved and also compression. So in terms of designing an orthotic to help load manage or optimize the plantar fascial performance, all of these roles need to be considered and the type of foot type or biomechanics that your patient has. So can we help with an orthotic or strapping? Can we help stabilize the arch? Can we help during propulsion in terms of plantar flexing the first ray? Can we reduce the amount of force needed within the foot for windlass activation? Can we help during loading? Can we moderate some of the different types of loads on the structures of the foot with the architecture or the design of our orthotic and the materials that we choose? So there's not just one single cause of plantar heel pain. There's multiple factors that will combine to contribute. Some of these factors can include things like body weight, aging and what fat pad condition or fat pad anatomy, loading, training volume, what surfaces the person's standing on or exercising on, footwear characteristics, and of course, like we've already touched on, their foot type and biomechanics can contribute to the overload, and there might be a systemic disease as well. Most clinicians will have their go-to treatment options for plantar heel pain depending on the presentation. The ones we will look at today, we'll look at padding and strapping.
because they're the ones that are most closely related to working out what your orthotic prescription could be for that patient.
Successful strapping is probably one of the best indicators that orthotics can work. Different styles of strapping are used for different presentations. You might concentrate on cushioning of the fat pad if it's more of a fat pad presentation or bursal presentation, or if it's more along the actual fascia, insertion of the fascia, you're going to concentrate on the fascia in its role. It might be in terms of obviously just helping support the fascia, helping plantarflex that first ray, so helping it in its role.
So low dye strapping is one of the most popular types of strapping for plantar heel pain, the aim of which is to help reduce the load and help support the fascia in its role. We did this very much by stabilizing the midfoot. You can see the bands of the strapping tape. I'm really concentrating around that midfoot area, so helping to stabilize that area of the foot. Additionally, stirrups can be added at the rear foot, and this can help to change the rear foot position and rear foot mechanics. So this is commonly added to invert the calcaneus in a pronated foot, so it's therefore going to reduce the load on the fascia during that elongation period or that loading. So this would have a similar effect to placing a rear foot wedge on the patient's insole. If we're looking to also influence the forefoot, the addition of strapping of the forefoot to the first and the fifth ray can help reduce the load on the fascia and assist with the windlass mechanism during the propulsive phase of gait. So this will help assist the peroneus longus to stabilize the first ray and plantarflex the first ray, helping us with our first MPJ and windlass function. So this would have a similar effect as other medial and lateral arch characteristics of an orthotic, in addition to forefoot lateral wedging and additions like a reverse Morton's extension.
So if you're interested in a really good dive into strapping techniques, Simon Bartold, put the link there, has a taping design specifically to address the factors involved in a pronated foot and plantar heel pain. And when we have a look at what he's trying to achieve with his strapping, he's trying to reinforce the plantar fascia statically, so in stance, and obviously dynamically when movement, reduce the load on the fascia, stabilize the midfoot, invert the calcaneus, facilitate the action of the peroneus longus by stabilizing and plantarflexing that first ray, and to plantarflex the forefoot on the rear foot. So if you had success with that strapping, they're the type of things that you'd want to do with your orthotic design as well. So moving forward with your prescription, you'd want to think about the architecture of your orthotic, the wedges, the arch support, the lateral arch support, all of those different things, and the materials you'd select, you'd want to try and mimic what the strapping had done.
In terms of treatment-directed testing with padding, plantar heel pain will often respond very positively to cushioning, either with a change of footwear or the addition into the current insole of a pour-on heel pad or a cushioning layer. You can support the midfoot and reduce the load on the fascia with a medial arch pad applied to the shoe insole. This works a similar way to the fascial strapping of the low-dye strapping. If you want to apply either a medial or a lateral orthotic reaction force to the rear foot, you can do this with a rear foot wedge. This would help to address foot mechanics in either the pronated foot or the supinated foot, similar to the rear foot strapping stirrups. If the patient fails the lunge test showing an ankle equinus, this can be addressed with the addition of a heel raise under their current insole to treatment-directed test. And if the patient fails the Jack's test showing signs of a functional hallux limitus, then a reverse Morton's extension or a forefoot valgus wedge can be used to help plantarflex the first ray and improve the windlass function similar to the forefoot strapping.
Just a quick discussion about research and what research says about plantar heel pain and orthotics. As usual, it's mixed. Students often get confused by this. How can the research be mixed when we know when we use it in clinics for our patients, we have such positive results? This is where the concept of individual effect comes in and dose. So individual effect is, if Luke and I both presented with plantar heel pain, I can guarantee that the treatment of our plantar heel pain, especially or even our orthotic design, including our orthotic design, would be slightly different. And there's many different reasons for that. It could be body weight, it could be foot type, it could be biomechanics, etc. So often within research design, you're given one type of orthotic design. And if we were given one type, it might not fix either of us, or it might fix one of us, help one of us, and not help the other. So this is where those inconsistency in results for patients. Even if, let's say, it's the right orthotic design in terms of its attributes, the dose might not be right. So what's the kind of concept of dose? Very easy to think about in terms of headaches. Might take me one paracetamol to feel better, and take Luke 3. So even though paracetamol was our answer, the dose wasn't right. So say with an orthotic, even if an antipronatory orthotic was correct, the dosage in terms of the degrees or the orthotic reaction force might not have been enough to help Luke, but it was enough to help me. So moving forward, this is obviously something that we need to consider in terms of our orthotic design, getting the design right for the patient presentation, which is what we will focus on.